General Principles of Randomized Controlled Trial, RCT. Number 1, the Randomized Controlled Trial, or RCT, tests efficacy of a medicine under ideal conditions. The first step designing a mathematically rigorous randomized controlled trial is to write a protocol. This is a document that completely describes the study you are going to do step by step in detail. Number 2, the next step is that the study is designed completely before any patients are recruited. This is a prospective study. Number 3, the next step is careful and specific remedy selection and patient selection. In the case of homeopathy, both these criteria are satisfied by the simillimum. Prescription of the simillimum implies that both the medicine and patient are correctly matched regardless of clinical or pathological diagnosis. Number 4, the next step is random allocation of patients to treatment and placebo arms of the study. Some patients are randomly given medicine and some are randomly given placebo. Examples of methods that could be used to randomly allocate patients are coin toss, random number generator, dice, lottery machine, and raffle drum. Number 5, the study must use medicines and placebos that are indistinguishable to the investigators and patients. Number 6, the next step is that patients are given medicine or placebos double-blind, which means neither the patients nor the homeopaths know if any participant in the study is getting treatment or placebo. Number 7, small numbers of patients in a clinical study rarely suffice. The study must have a big sample size, not just 20, 30, or even 100, but several hundred or even thousands. Typically, 1,000 to 3,000 in a Phase 3 study by pharmaceutical companies. Number 8, if the above mathematical assumptions are satisfied, then the resulting statistical analysis produces evidence of an extremely high degree. Number 9, there are higher and lower levels of evidence when testing a medicine's ability to have a desired or intended result. A medicine's ability to have a desired or intended result is called efficacy. The most mathematically rigorous test of efficacy is a large sample size double-blind randomized controlled trial. The RCT tests efficacy of medicines under ideal conditions. The other types of studies are called effectiveness studies. Effectiveness studies test how a medicine performs under normal daily conditions of use. They are not as mathematically rigorous as the RCT, even with embellishments, such as multivariate analysis. Their quality may vary from quite rigorous to not very rigorous at all, or from somewhat mathematically exact all the way down to this. There are many different study designs that can be used to answer clinical research questions. A. These include systematic review and meta-analysis. B. Randomized controlled trial. C. Cohort studies. D. Case control studies. E. Cross-sectional studies and surveys. F. Case reports and case studies. And others including editorials and expert opinion. Going from left to right, one goes from extremely mathematical rigorous to increasingly speculative. Note that systematic reviews and meta-analyses of clinical studies are the highest levels of evidence. Such studies only deserve their peak position in the hierarchy of evidence if they are based on RCTs with identical design and with big sample sizes. Systematic reviews and meta-analyses often do not fulfill this condition and therefore transgress mathematical assumptions for reliable results. They are open to bias and confounders. In the ideal case, the meta-analysis would be designed even before the identical RCTs upon which it is based are performed. The quality of meta-analysis is important for systematic review, since systematic review obtains its ultimate authority from the meta-analysis it contains. Reviews and meta-analyses at risk of bias and confounding do not outrank a properly conducted large sample size RCT. Biased or confounded studies fall significantly down the hierarchy of evidence, even all the way to the bottom. A meta-analysis or systematic review based on studies with different designs could be called a MANO or SRINO. This means meta-analysis in name only and systematic review in name only. In the worst cases, calling such studies meta-analyses or systematic reviews can be like putting lipstick on a pig. No number of editorials, expert opinion, or committees at the bottom of the evidence hierarchy and unbacked by data at the top will improve their validity. One may recognize such data as it is prone to cause fights amongst people of differing opinions. In conclusion, the prospective double-blind randomized placebo-controlled study is the design of choice with the greatest validity for investigating efficacy of medicines that can fulfill the design criteria. Identical studies can then be meta-analyzed meaningfully.